So continuing on the theme of CMV co-infection, the one potential conflict of interest is that the testing kits for this study were donated in kind by the Altona company. So before we dive deep into the subject, just a brief word about the global burden of CMV infection. I know many of you here are pediatricians, so you're well aware, but CMV is one of the most common chronic herpes virus infections. There are a large number of studies trying to estimate the global seroprevalence, and this predominantly in women of childbearing age, given the implications for congenital CMV. And the estimates are anywhere from 50% in a low prevalence country such as mine in Canada, as high as 90% in some areas. And this is an infection that's acquired usually very early on in childhood because it's spread so easily through saliva or through breastfeeding. And immunocompromised hosts usually have very mild or if anything asymptomatic infection. And it's really an immunocompromised host that we worry about CMV pneumonia, as we just heard, hepatitis, and pneumonitis. So why worry about CMV in the context of HIV? Of all the herpes viruses, CMV is the most dynamic, that has the highest level of interaction with our human immune system. Infection elicits a very high number of CMV-specific T cells that basically engage in this lifelong response in the host to inhibit CMV replication. And it's estimated that in healthy individuals, up to 10% of their circulating T cells, their CD4 and CD8 memory T cells, are really CMV-specific. So you can imagine this lifelong battle between HIV and CMV in those who are co-infected. And there's considerable, very good data in the adult population that shows that despite effective treatment with ARVs, adults who are just co-infected with CMV have signs of chronic inflammation, immune activation, and really a persistence rather than a natural decay of their HIV reservoir, and really concerns about immunosenescence. The data in children, however, is much more limited, but I'd argue is potentially much more concerning, because what's unique with children is that they're acquiring both these infections early in life. They're getting HIV in the perinatal or in the breastfeeding period at the same time, which most likely they are also getting concurrent CMV infection. And so what is the potential impact of having these dual infections on their developing immune system? So that was the objective of this study, was really to look at the prevalence and the risk factors for CMV co-infection and CMV viremia among Canadian children with perinatally acquired HIV. And as a secondary objective, we wanted to look at CMV co-infection and immunological outcomes. So this is a sub-study of our Canadian EPIC-4 cohort, which enrolled children between 2014 and 2018 across 8 centers in Canada. Children had to have been perinatally infected, but this was cross-sectional, so they could be at any age at study entry. And they were followed every 3 to 6 months with extensive blood sampling for that 4-year period. And to document CMV status, we did serology at baseline using standard serology using the Architect assay. And for those who are under age of 2 or who are seronegative at the start, CMV serology was repeated at the end of study. And then both CMV and HIV viral loads were measured at every clinical visit, as well as HIV lymphocyte subsets. We measured CMV using the AltoStar kit, which had a limit of detection of 250 international units. And CMV viral loads were tested using our national clinical labs. And following this morning's discussion, we were very stringent and we used a detectable viral load of over 20 copies as detectable viremia. So this was our EPIC-4 cohort. We had 225 participants, so the average age was quite old at 14, and the majority were not Canadian born, so they had been diagnosed upon immigration. Nearly 99% were on treatment at the start of the study, but unfortunately only 81% were actually virally suppressed. And not surprisingly, 85% were CMV seropositive. One child acquired CMV during the study period, so a total of about 86% CMV seropositive. So the first thing is we looked at the difference, and not surprisingly, those who are CMV seropositive were more likely to be foreign-born, coming from higher seroprevalence countries, and were also older at the age of their ART initiation, again likely because many of them had been diagnosed at time of immigration. So we first looked at CMV serostatus and clinical outcomes because there's quite a bit of data in the adult population showing that just being CMV seropositive has an adverse clinical outcome. And not surprisingly, we didn't see any major differences between those seropositive and seronegative in our cohort. But again, this is a very short study follow-up period, and in general, these events are now rare where children are under effective therapy and engaged in care. And now the more interesting results is the first thing we wanted to look at was CMV serostatus and the impact on their lymphocyte counts. And even if our numbers are small, what was really impressive is that those who are CMV seropositive had lower absolute and relative CD4 counts, and more concerningly, lower CD4-CD8 ratios, both at entry into the study and during their study nadir. And this was significant after we adjusted for the presence of any HIV viremia during the study, their age at treatment initiation, and whether they'd had any treatment interruption during the study. So overall, lower CD4 and a lower CD4-CD8 ratio. We then looked at that subgroup that was CMV viremic. So of the 192 that were seropositive, 18% had had at least one episode of CMV viremia during the 4-year follow-up. And then we looked at CMV viremia, so whether having one episode of reactivation changed your lymphocyte parameters. And interestingly, in this case, reactivating your disease did not show any clinical impact on CD4 or CD8 ratios. There was a slight signal with those who were CMV viremic in their ratios, but this did not persist after we adjusted for the presence of HIV viremia. So then we looked at those who were viremic and who weren't viremic to try and understand whether we had any differences and we could predict who was going to be viremic. And the only thing that came out significant here is that those who had at least one episode of HIV viremia were twice as likely to be CMV viremic. So then the question was, what comes first? So is it that you lose your HIV viral control and then your immune system loses CMV viral control? Or is it possible that it's the reverse, that somehow you reactivate your CMV and in the battle to contain that, you lose your HIV control? So we tried to look at that to try to figure out which is coming first. This slide is a little busy, so I'll walk you through it, but that was the basic hypothesis to see which viral control you lose first. And so on the first figure in blue, we looked at whether or not, if you had CMV viremia, was that preceded by a prior episode of HIV viremia? So on the x-axis is those who had HIV viremia, and on the y-axis is their current CMV viremia. And if you look, there is a clustering of children who had CMV viremia immediately preceded by an episode of HIV viremia. And when we modeled it, yes, it was statistically significant through a basic correlation coefficient. And in the adjusted model, where we adjusted for repeated measures, it remains somewhat significant. And then we tried to do the reverse. When we looked at whether a child who had HIV viremia was that preceded by a prior episode of CMV viremia, it did look like it clustered again in that same pattern, although the significance of these models was less significant. And my analyst tells me not to read too much into it, but it does look like the signal would be that having HIV viremia will lead to subsequent CMV viremia. So in summary, in our cohort of Canadian children, 86% were CMV seropositive. And among those who were seropositive, 18% were viremic for CMV at least once during the follow-up period. And I think most interestingly, those who were CMV seropositive had significantly lower CD4-CD8 ratios and lower CD4 percentages during the entire follow-up period, even in the adjusted models. And CMV viremia, though, did not impact these parameters. However, there was an association between CMV and HIV viremia. So what is this? And so before we take this too far, our study does have a number of limitations, the most significant being that it was a really short follow-up period, so potentially too short to determine any non-AIDS events. It is a very heterogeneous cohort from across the country of children with perinatal HIV infection. We had a large number of confounders that potentially we could not adjust for in our models. And measuring CMV every 3 to 6 months is potentially too short to actually detect all episodes of viremia. And finally, it is a small cohort of children living with HIV. But what does this mean? What could this potentially mean? And again, this is data from the adult population showing that having lower CD4-CD8 ratios does have an impact in the long term as a potential driver of all of these chronic comorbid conditions. And in the adult population, they're really looking at the drivers of these low ratios and are including these chronic latent infections. And so we just have to wonder whether having this on board for children who have this lifelong chronic dual infections could potentially impact growth, cognition, and eventually lead to immunosenescence. And I say this not to end with doom and gloom, but because the field of CMV is growing exponentially and there's quite a lot of new treatment options in the future. There are newer antivirals such as letermovir, maribavir that are much less toxic than ganciclovir, which we've been reluctant to use. There are randomized control trials happening in adults looking specifically at the use of these newer antivirals on chronic inflammation and gut inflammation. So the thought being, could potentially treatment with these antivirals for children living with CMV improve their long-term outcomes by reducing inflammation and really ultimately decrease their long-term morbidity. And again, CMV vaccination is on the horizon. Clinical trials are underway, and so in an era where we will have to prioritize vaccine, maybe children with HIV could be prioritized. And so I'll conclude here with just future directions. I think the world of CMV is expanding, and there is significant interest in potentially targeting this and understanding its role really among people who are living with both viruses to see whether it is contributing to inflammation, immune activation, and reservoir decay. And there are clinical trials underway looking at these newer antivirals and dosing in children. So with that, I conclude, but not without thanking the entire clinical cohort team, and especially acknowledging our clinical fellow, Dr. Yves Fougère, who's done an extraordinary job looking at this data and unfortunately couldn't be here today. Thank you.